document or consider scheduling another session. We feel like these have been really successful so far. We really appreciate your guys' participation with all of this. Let's see. So we will be respectful of everyone's time and conclude at 11:30 at the latest. And this series will serve as our annual CMA training and any additional forums like this that we have. So we are capturing attendance. Normally we have a sign-in sheet in person, but attendance for today's training will be captured by Google as you've logged in. For those who are participating by just calling in on your phone and entering the passcode, only the last 4 digits or so of your phone number are captured. So if you could please use the chat function and send us your name and email, that would be really helpful. And if you participated in the last session for last week and were not able to fill out the Google form, we only had 31 people captured in attendance. So if you participated last week, please just use the chat function, email, and session 1. Just indicate that, and that will meet that need. So we've been getting some great questions already in the chat function. We're going to start with Appendix K questions and general questions, and then we do hope to save some time for introducing and going over the price approval policy. So if we're still going by 11 o'clock, we will pause and kind of switch gears to that discussion. And I think we have some questions that have come up already about the price approval process, so we will save those until the 11 o'clock hour, or if we transition over to that topic beforehand. All right, I think we're ready now. Okay. Any guidance on porch or outside visits 6 feet apart this spring or summer if the case manager is vaccinated? Clients are asking this a lot. Essential visits for those, well, this is a 2-part question. Okay, so for the first part of that question, same thing we did last year with porch and outside visits and window visits, that will be allowable. Masks, you should still be wearing masks. So you can tell your clients that yes, you'll be able to do that. And then what about essential visits for those in individual residents that are not facility-based? Are window visits allowable for needed items or safety checks? And yes, window visits are allowable in that instance as well. Precautions should still be taken, like wearing masks. But we do want to emphasize that when there's a health and safety risk or crisis or immediate need that cannot be met in any other way, we do support in-person visits with appropriate PPE. For those who are in assisted living, the kind of health and safety risks we're talking about are human rights restrictions, abuse, neglect, exploitation, or meeting immediate needs. Like a situation came up on another program where home delivered meals was in place, but the individual couldn't pick them up off their porch. So that is something we would support an in-person visit for, because we want people to get their food. So just use your best judgment. If you have questions about what we support or not, please feel free and reach out to us and staff individual cases. All right, have you sent out the letter to ALFs you talked about in the last call regarding not visiting face-to-face for the time being? Not yet. It is drafted and being reviewed for approval for being sent out. So that will be done either today or tomorrow. What should we tell buildings who are upset that we are not coming in, especially those who are stating that they spoke with New Choice's waiver and were told it was up to them and the case management company if we should come in. If that is the guidance they received from staff, that is something I will address. But since March, April, May, it's kind of all fuzzy, of last year, in-person visits have been disallowed. So this is not a new policy. This is something we should have all been on board with for the last year. And we will support you with this letter going out. Everyone on my team is aware that that is the expectation. So we will all move forward on the same page together from this point on. Under Appendix K, CMAs have the option to purchase hand sanitizer, DoorDash, etc. based on client need. Please review how we put the meals and supplies on the care plan. What exactly are you wanting on care plans for each of these services? That is a great question. So for the DoorDash services, you should be reaching out to us first for approval. That's not something that is available across the board in a free-for-all type of way. That is available to address specific instances where that is the most appropriate option. We do want to make it available, but it shouldn't become the default. So reach out to us and just send us an email saying these are the circumstances, community-based or DoorDash food delivery services will be needed, and estimated duration. And we will communicate with you that that can be added to the care plan. You will still be using the home delivered meal code. The max allowable rate has been adjusted up to $25 per unit for that service. So you are able to list yourself as the provider in that instance and bill Medicaid directly and reimburse the participant or yourself, however that payment arrangement has been made. For hand sanitizer, let me pull up the Appendix K guide. You may be surprised that we don't always have everything memorized, but we do our best to know things like the back of our hand. I don't want to misquote the information. So let me pull this up and we can go over it. I want to say that it is being allowed under specialized medical equipment, but let me just confirm that. Okay, so the language from the provider guide addresses the availability, but I guess you're right, it does not get into the nitty-gritty process of this. So though personal protective equipment like masks, gloves, and item for disinfecting can be purchased for waiver participants' own use under the Specialized Medical Equipment Code. And case management agencies can make that purchase directly and be reimbursed for providing the service. You can either choose to go through Acumen, through the FTS process, or you can list yourself as the provider and bill Medicaid directly. You will have to be an enrolled provider for specialized medical equipment. Some of you are already enrolled providers, kind of left over from the pre-FTS days. So if you are not an enrolled provider for specialized medical equipment, you should go through Acumen. And Blake can be your contact for questions about whether or not you are an enrolled provider for specialized medical equipment. In this last iteration of the guide, we added that you guys may purchase PPE directly from adult residential services providers. We understand that those providers sometimes have a supply that is more readily available than the DME companies. And so we wanted to provide a way to access equipment and supplies through that channel. And it will be the same thing where it can be reimbursed by billing Medicaid directly under specialized medical equipment T2029, or you can go through Acumen's FTS process. Okay, next question. I had a building tell me last week that they spoke to DOH and were told that CMAs should be coming in to visit clients. Could you email me and let me know who you spoke with? We may be running into an issue where if you're speaking with somebody at health facility licensing, they have allowed visits to occur again. But as a program, New Choices waiver specifically, our position is that we are holding off on that for now. So if you could email me and let me know who you spoke with, that would be great. If we have reached the 24-month mark for the first extension and a video call is not feasible, are we allowed to do face-to-face? I guess it would depend on any other creative solutions. So if you've already reached the 24-month mark and an assessment through telehealth or collateral contacts or gaining information from providers in conjunction with a phone call from the participant, all of those cannot be done. And we expect that all of those options are pursued before coming to the conclusion that it's not possible. Then yes, an in-person visit can occur. But again, that should not be the default. We appreciate the efforts that you guys have gone to this point to be very creative and come up with solutions. And we hope and expect that that will continue to be the case. Can you send an updated staff list and the breakdown of the alpha split and what days we can contact them? Yes, we can send you an updated staff list and a breakdown of the alpha split. Just for your guys' information, this is a good time to let you all know. Amelia Self has taken on the role of assistant program manager. So she is overseeing operations and I am overseeing the program, but focusing on quality and service design. So as we are undergoing kind of an organizational structure shift, we are looking at our processes and how we split up work. So in the past, there was clear delineation of who was doing what, and that may not be the case anymore, depending on how things are divided. So we can give you a general breakdown of who is doing what. It's subject to change. If you have a question and you're not sure who it's supposed to go to, your go-to method of communication can be emailing newchoiceswaiver@utah.gov. Let's see. It would also be helpful in the alpha split if you can add a column that states special assignments each staff member does, for example, incident reports, ALF referrals, etc. We will do that, but we have a goal of cross-training across different areas of the program. So it will not always be the case that who you contact is the person who's addressing that specific instance, but we will try to provide more clarity. Will New Choices Waiver be sending out policy to the providers regarding the new price per unit? Yes, we will. Do we need to have rural enhancement for case management units that are over 25 miles when we open up on the care plan? For the rural enhancement, you should be noting in the comments that you are intending to access that. There are specific requirements in policy that have to be met. And if that is a topic where you guys are wanting clarification, we can go over that. In the last review, it seemed like not many agencies would be eligible for it based on some of the policy surrounding it, but we can definitely go over it as a topic or send out an FAQ or a fact sheet. That might be the way to go. So we will address that. Last session, it was mentioned that we have 60 days to get med reviews completed. That is 30 days before and after the due date. Sometimes it is taking longer than this to get information from the providers or facilities. In this scenario, do we just document the phone calls and faxes that we have been doing for follow-up to get a medication list? Yes, I think that is a really great solution. We do allow essentially that 60-day window so that you can complete these activities. And as best practice, we would encourage you to start these activities the 30 days before it's due, not waiting until the last week of the 60-day window. But yes, it would be appropriate to document your efforts. I think that is that will be sufficient for when it comes down to looking at processes. All right, we kind of went through those really quickly. We're on a mission today because we were expecting lots of questions. So we'll take a minute and let some more come up. Some more questions about the rural enhancement, and yes, we'll do an FAQ about these. All right. Existing clients assessed with an MDS after 11/1/2019 had a medication management form started. After 4/1/2020, no MDS was done for existing clients. Their care plan was extended 12 months. No medication management form was started. Starting 4/1/2021, all existing clients will be assessed again, including a new MDS and medication management form. This leaves a gap for existing clients only who did not have MDS between 4/1/2020 and 4/1/2021 that never had an MDS or initial medication management. So we understand that we're running into scenarios where our guidance was not very clear, and we do not intend to penalize you guys for that. I think there was acknowledgement that in the beginning of this med management process, our goal was to just get everybody up and running. We are not at the point of auditing this. that may come up in the future as a quality assurance effort. Certainly, it's an effort where you guys are auditing your own records. And, we hope and expect that that will be accounted for accurately on the quarterly self-audits that you do. But we're coming from a place of understanding. Our guidance was not clear. There is still confusion and questions surrounding the time frame in which to complete them, and its relationship with the MDSHC versus the care plan. And it sounds like we need to create an FAQ document for that as well. So we'll create an action item for ourselves for that and go over it again. But the main takeaway from this question is just that I want to communicate that if things have been missed, just start doing them as soon as you identify that it was missed. It was not communicated but it was assumed that last year med management forms would just continue to be completed based off of the assessment, and rather than 3 subsequent reviews after the MDSHC, you would have quarters 5, 6, and 7 completed based on that MDSHC that was done initially. We understand that there's confusion there. So if you're discovering that reviews were not done last year, you can go back and backtrack and start a quarter based on the review schedule and pick up from where it should leave off. If you have questions about the timeline of this, we are available. Feel free and email Marisol or New Choices Waiver at utah.gov, and we will staff individual cases with you. But if you are doing assessments now because of care plans that have already been extended to 24 months, it would be appropriate to resume med management reviews and have a plan to review them every quarter. New Choices Waiver instructions were to start these reviews for existing clients assessed after 11/1/2019. Currently not being audited formally. If something has been missed, oh, I'm reading the answers that Amelia captured, not the question. Sorry about that. All right, so truly the next question, not Appendix K, but issues with the transfer and not receiving the closing care plan so we can start the new one. Transfers are challenging. They need their own FAQ, but we can go over this. That when there is a transfer, the old CMA will add the new CMA's units onto their care plan, close out the care plan, and then the new CMA starts a care plan with only their services on it and no pre-enrollment, just regular case management from the date of the transfer forward. So if there is an issue with not receiving communication of the closing care plan, so we can start a new one, we need to work on our collaboration efforts when transferring from one agency to another. And if it's because the expectations are not clear and the process is kind of stumbly, then we can work on that with clear step-by-step instructions. But I do think there's an opportunity to work on collaboration there. We've started meeting with individual CMAs for the quality improvement efforts that we're doing, and that's something that we're hearing pretty consistently, is that you guys are wishing that there was a forum where you could staff questions as a group and learn from other agencies how how and what processes are being used that could be considered um, based on best practices or things that you've found that are working. We know our group is a little bit unique, where in a sense there is competition, but I think we can build beyond that and all be partners in this effort. We all have the same common goal. There are great resources in our group, and I would love to see that happen. So we're planting seeds and working on getting to that point. Um, and I think we'll get there. Someone just said it would be nice if New Choices Waiver could let us know when the new CMA care plan can start. The sending CMA does not always let us know. I attribute that to a process breakdown, and we can work on that process, whether or not that's us communicating it. To date, the expectation is that the two agencies establish that transfer date. And you're right that there is a delay between when the care plan was submitted and actually reviewed by us. So we are probably contributors in some of that challenge, and we can work on that by establishing a process and how we can help as facilitators. Someone mentioned a contact list for other CMA supervisors would be great. I would love to do something like that. So we will work on that and kind of get some feedback individually as we're meeting with agencies to get a feel for how to best accomplish those efforts. Someone commented, when transferring cases, I may request a care plan to be closed. However, I do not know if it was closed unless I check it daily to see if New Choices Waiver staff closed it. When the care plan is approved for other agency units, I request the closure and create a service authorization. Send the care plan showing their units, and at that point, believe my role in the transfer is complete. That's really great insight. We will use that to create an FAQ for the process, and it may be appropriate for us to create an outline of what we think occurs, because it's sounding like what occurs in practice is different than what we think occurs. And I think finding the solution is not just going to be one-sided. This input that you guys are providing is valuable. So I think we can come up with a solution together. If you have any, I opened up the can of worms. So if you have items relating to transfers that you feel like our stated procedures do not align with the challenges you guys are facing, or there are nuances that you feel like are not understood by us as we're creating this guidance, please email me directly. I think, maybe that may not have been welcome in the past, but we've got to find a solution because this is a challenge for us and clearly in the field as well. So we will collaborate there. You're welcome. I think we all have the same goals in these transfers, looking out for the best interests of the clients and working together, because it's a difficult process for the client as well as for providers. So I'm hopeful we will find a good solution. So we've identified a couple of FAQ documents that we need to go over and specific training items. It seems like the Appendix K questions have wound down. So if there are, other items you would like FAQ documents on, feel free and pop those in the chat. I'm sure more will come after this meeting, but this has been really great insight for us. So we really appreciate that. Sorry to create more work. It's okay. We create more work for you guys, so it can be reciprocal. It's fine. But really, we're supporting each other at the end of the day. We wouldn't have a program without you. And, we are supporting businesses at the same time and jobs for our professions, nurses and social workers. So we are dependent on each other and need to collaborate. All right. So it's kind of coming to a pause. Oh, good. There's another one. As a supervisor for the agency I work with, I often have seen misinformation being shared between providers, other CMAs, and clients. This could be reduced by having CMAs knowing each other, knowing how each of us operate and our structures. I support a way for CMAs to connect. Thanks, Wendy. I think a lot of people share that sentiment. It may be new and a little nerve-wracking because relationships to this point may not have always been so collaborative and supportive. So I really appreciate those who are speaking up and saying, hey, I think we can do this better. We relate to that as well. Any idea how long Appendix K may be in place? That is a good question. So it is tied to the public health emergency that is declared on a federal level by the Department of Health and Human Services. And that is currently declared January 2021 through April 2021, and has been renewed every 90 days since the very beginning. CMS gave us recent clarification that states have a transition period of 6 months after the end of the public health emergency to move from Appendix K policy to whatever the new normal looks like. There are some instances where states, we're in the same boat, have learned that, hey, some of these flexibilities in Appendix K actually work and are good practices for ongoing. So we're looking at areas that could be incorporated into normal policy. So if the public health emergency is not renewed beyond April, we'll have a 6-month window, and that puts us into the fall. I don't have a crystal ball, but I think we all share that it is likely to be renewed based on the trends and where we're at, but we never know what will happen. We do have a good cushion, and I think that's reassuring because then hopefully we have learned a lot of lessons in implementing Appendix K that will help us implement the new normal policy, hopefully in a smoother way than how it was implemented in the beginning. I think from my perspective, I acknowledge that information was not always available as soon as you guys would hope, because we were still figuring out a lot of it as we went. And having a 6-month window instead of a 1-month window will offer us a lot of opportunity to have more of these forums and eliminate confusion and make things more clear. So Another process we will collaborate on. Will this waiver be affected by the combination of the Department of Health and Department of Human Services? Probably. It's our understanding that our Bureau, when I say we, I mean the Bureau, will go be incorporated into the new DHHS, Department of Health and Human Services. We don't know what that organizational structure would look like. I have my own speculations, but I'm not going to share as a representative of the state. That wouldn't be appropriate. But to my knowledge, we will be in the new merged agency, and we will see what information is available as it comes out. But as we're learning, the plan for implementation is not slated to actually start until July of 2022. So there's still a long way to go. There's a length of time where the agencies have to make a plan and present it to the legislature, and then another span of time before it's actually going to be implemented. So we will navigate that change as well as the return to Appendix K when it happens. Are the medication management review forms supposed to be submitted at any time, or are we just keeping them for possible future audits? That's a great question. At this point, it's a combination of not having capacity to audit them right now, and also not wanting to unnecessarily burden you all by asking you to submit documentation that we cannot review at the moment, because everyone's workload has been impacted by COVID. So, as I mentioned earlier, the reorganization of my team was done intentionally so that we could focus on quality improvements in operations and also services. So our main quality improvement focus right now is the CMA audits that you guys are doing of your own work and how we can add value. It's not off the table that we kind of do a post-audit of the medication review forms. If that were to occur, I think I can speak for Marisol and I when I say that we would be coming from a place of education first and foremost, because what happened was we created an idea of how things should occur, and we've never regrouped about what's actually occurring and what challenges you're facing. So based on the questions that are being submitted, there are obviously ways that we can improve upon the process before we get to the point of auditing to determine compliance, because we have to get the operations side worked out before we can really hold providers accountable, because how can you be accountable to something that is unclear? So please don't stress too much about that, but in the future, we do plan to make this a meaningful activity and build on what's already been created. When adding memory care mid-care plan, is it necessary to complete a new PCCP to complete the modification section at that time, or can that wait until the annual assessment is due? So I think this is a great question and something that is on the list of quality improvement projects. We recognize that you guys are auditing yourselves for addressing health and safety risks in the PCCP addendum as the care plan progresses, and auditing for the modification section, which should be completed with every memory care placement. So it would only make sense that you would update that form as it occurs, but we haven't made a process for that. So we will, And I'm open to suggestions that you have about how that could be incorporated. You know, there's the option of including it with the memory care checklist as just a second document that's to be submitted when you're requesting approval. And then uploading that at the same time and in the normal process. That feels like a natural fit from my perspective, but I don't do the process. So perhaps there's something that makes more sense in practice. So be thinking about that, and feel free to send me an email directly, ldavis@utah.gov, with your thoughts about how that should work. Please review the ALF application process as New Choices Waiver sees it. Besides the open enrollment changes, open slots, are there any other ALF app differences between Appendix K and regular time for applications? This is a really good question, and I want to be transparent that we are doing the best that we can to share information as it's available, rather than being closed mouth about it or tight-lipped about it and waiting until the last minute. I'm sure you guys can relate that there is a lot of work now being done that we didn't need to do prior to COVID. So with the timing of everything, I'll be honest that all of the details surrounding policy and procedure with what normal AL application will look like has not been flushed out yet. I can share that we are undertaking a health policy research project to research how other states have addressed this. We do know that other states have very similar programs that are referred to as an assisted living waiver. And individuals can apply from the community or from the assisted living without having to go into a nursing home. So I want to be clear that we don't know if that's the direction we're taking. But at this time, all that we know is that CMS has clarified that the open application periods as they were established before is not in line with their interpretation of policy. New team members and new staffing has occurred at CMS. And as I'm sure you've noticed with just the changes in our team, new staff means new interpretations. And so we are going along with the new guidance that we've received, which was the open application periods are not in line with the policy. So I don't have an answer for exactly what a normal AL application process will look like. But I do hope to have an answer within the next few months, because it is fair for people to want to know what to expect. So please be patient there. I'm sure you're having assisted livings asking and folks from the community, and we will share information as soon as we can. All right. Any more questions? We'll give it a few more minutes. Are you guys okay? Do you want a 5-minute break before we segue into the next topic of the price approval process? We don't want to lose anybody, so don't go anywhere. But if we're feeling like a break is necessary, then we can pause and regroup at 11. You can unmute and tell me what you think.
I like it. Nice.
Break would be nice. Is that what I heard? Okay. So let's take a 5-minute break or 7-minute break and come back at 11. And we will go over the documents that you sent out, or that Amelia sent out about the price approval process and how that should look like, and have some conversation about that. Okay, we'll see you back in 7 minutes. Just to reiterate, don't go anywhere. I'm seeing people leave. Come back. All right, everybody, are we back? Let's regroup. Thanks for taking a break and still coming back to us. I'm glad nobody left. Okay, so we are going to pitch it to Amelia, who's going to present some information about the per unit policy that went into effect in a couple months ago that we are now implementing. So take it over, Amelia.
Okay, great. Thanks. So as Lainey indicated, my name's Amelia, and my new role with the New Choices Waiver Program is as the assistant manager. Just a little bit of background. I'm a master level social worker that has spent the entirety of my professional career working with vulnerable populations, specifically with refugees, people living with HIV, and most recently the New Choices Waiver Program, which I joined a year ago. I've probably communicated with a lot of you, either when I was assisting with applications or incidents or for various of reasons. I'm coordinating hearings as well. So it's nice to interact with you all, and I'm excited for this new opportunity to work more closely with you in this new role. So as Lainey said, we're going to spend some time talking about the price per unit policy, which some of you may be familiar with because it was included in the October 2020 Provider Manual Update, which I know you all read thoroughly and you're very informed about all the changes and corrections to that manual. So Tracy says she does, so good job. So today we're going to walk through it. If you have questions while I'm going through it, please just add those to the chat. We're going to have this go into effect April 1st. So it gives us some time to tweak anything that we learned from your feedback today or some considerations that we maybe hadn't accounted for. So we really do want your feedback. As I said that, I shared the policy along with the revised service authorization form in the email that went out to the case management agency supervisors. So hopefully you shared that with your staff. If not, I have prepared, I'll just present this so you can read through this as we walk through the policy. So you should be seeing a slide that talks about that. And if you guys, for whatever reason, if that's not coming through very well, I know sometimes it's a little hard virtually, but I can share these with you later, but essentially it's just the document that I sent out that we're going to talk through. So as I indicated, this price per unit will go into effect April 1st. And it's for specific HCPCS codes, and it will be required both in the comprehensive care plan and the service authorization. So as recipients of federal and state funds, the New Choices Waiver Program is responsible to ensure that these funds are spent appropriately and that any payments made for services are reasonable within the scope and the intent of the service. So for that reason, we have our established rate sheet, which you're all familiar with. And you'll recall that there are a few of our codes on there. There are a few services that don't have a set price. Rather, there's an allowable range. So what this policy is going to do, it's going to require that case management agencies provide a set price within that allowable range for the service being requested. And so we'll walk through what that looks like. So on the comprehensive care plan, you will need to list the price per unit, and it will be in the charge column. We've established some set price for common items purchased under T2029, and we'll go through that. But for all other services, the price per unit may not exceed the max allowable amount and should be reasonable, like I said, for the scope and the services being requested. If the price per unit is not included in that charge column, it will be denied. The plan will be denied. We also will be evaluating for costs to determine whether or not they're reasonable. So if you remember, you all love this screen. This is what it looks like on our end. This is a care plan system. I don't know what it looks like on your end. But if you'll remember, we added that charge column. So if you see that red arrow, that's where the charge column appears on our view. I recognize that your view might be a little different, but essentially you've listed the code, the procedure, the provider, the charge or the price, the units, frequency, begin date, end date. Okay, so that's where you're going to add the charge. So we're going to walk through the codes that this is applicable to. The first one is 5120, which is chore services. Currently, that is a set rate of $4.77 per 15 minute. We're going to have you go ahead and enter that rate on the care plan and your service authorization. This rate will be changing to be per episode once we finalize our new rate sheets. But for now, just go ahead and enter that price for that code. For 5165, environmental accessibility adaptations for the home, the max allowable range is $2,000 per episode. So you will need to enter the price that it will be for that service. Now, these are typically where we require bids. We still require the 3 bids, but when you're entering this into your care plan, go ahead and enter the amount listed on the lowest bid in that charge column, upload the 3 bids, and then submit your care plan. So we don't want you to have to submit multiple care plans in order for us to approve it, meaning submitting your bids first and then going back and adding it to the charge column. So go ahead and enter that price in the charge column. Any questions? And Lainey or Marisol, you'll just let me know if there's any questions so far.
Yeah, we did have a couple, and I didn't put them in the sheet, but I can read them out right now.
Oh, wait, okay.
And it looks like Marisol's starting on that.
Gotcha. I'll remember that that's there, so.
That's okay.
Yeah.
So the first question, more of a statement, it would be really nice if New Choices waiver staff were acclimated to what the care plan system looks like on the CMA side. We could not agree more. We feel like we are the least useful people when we get questions about where to navigate to when certain functions aren't working. That's also in one of our quality improvement strategies. So thank you for the feedback. We agree. The next question, our case manager is going to have to enter every price for every service.
So no, just for these codes that are listed here. So for 6 codes. Okay.
Another question that came up, sometimes we have reason to need the bid that is not the lowest of the 3 bids. Do we indicate that somewhere or just put in the lowest bid?
That's a good question. Lainey, do you want to address that?
Yeah, I think what we find, so there are a few fundamentals in philosophy and in policy that we have to meet with these bids and services. One is that Medicaid is the payer of last resort behind Medicare, private insurance, and natural supports. 2, that least costly alternatives have been explored. And 3, that the item is the least costly alternative that meets their needs. So how can I describe this? If there is a scenario where the lowest bid does not meet the needs of the individual, then you can explain that in the comments. If it is a matter of convenience, comfort, or aesthetics, and that is the reason why the lowest bid is not being requested, that will be denied. And convenience gets into a gray area where we're talking about assistive equipment. My advice there is if you have questions about how we're going to see a specific case, you're more than welcome to reach out to us first. The care plan or the alpha split is still in place for the care plans right now, and that information will be shared about team assignments, so that will make that easier. I know that's answering your question without really answering it, but hopefully setting forth those parameters of, explaining to us how this meets the needs in a way that the lower priced item does not. And then I think we are still maintaining or checking all of the boxes of fundamental philosophy that we have to stick by. Back to you, Amelia.
Okay, great. So moving along the list. So again, just a reminder, this price per unit policy only applies to the HCPCS codes listed here and in the document that we sent out. So the next one is T2028, assistive technology devices. So again, the range is that max allowable hasn't changed. It's $2,000 per item. You would list the actual price for that item per item. Okay. I really want to draw your attention to T2029 because we're treating this one a little differently. So most commonly under this code, we see requests to purchase personal hygiene wipes and nutritional shakes. We have, fortunately, we have cost information on those that is used by the DME providers. And so we looked at those costs for each of these items, and we took an average of those and determined a set rate for these items. So for personal hygiene wipes, the max allowable that can be entered per smallest unit is $10.15 each. So if you're requesting a package of wipes, the most that we will pay for is $10.15 for that. Now, obviously, a provider can charge less than that, but we won't be approving cost that exceeds that. And the same philosophy applies for nutritional shakes. And again, these prices were based on the actual prices that the DME providers were charging Medicaid, and we took the average of them. All other items under T2029 can be between that up to that $500 max allowable, but again, it's per unit. So if it's a bed cane and your DME provider is going to charge you, I don't know, $100, then you enter $100 in the charge column. I wanted to clarify, because I think this could cause some confusion. So let's walk through a scenario. So we have a participant that was prescribed 2 nutritional shakes per day. In the charge, you're going to list that $2.85 amount, $2.85, because that's the charge per unit. And the unit number is 2. So you don't have to do math. You don't have to calculate and say, well, if I'm going to give them 6 nutritional shakes a day, which isn't appropriate, but it's the example that we have, you don't have to calculate how much that's going to cost. You just have to enter the price per unit. I'm going to stop there and make sure that that is as clear as mud to everyone.
Crystal.
Okay, great.
Very good.
Yay, I did it. You guys are you're getting this. Okay, and so then if we go to our other services, T2038, this was previously referred to as Community Transition Services. We've renamed it. That's the only difference. It's Community Living Services. Again, the $1,000 is the max allowable per service. And then T2039, Environmental Accessibility Adaptations for the vehicle, the same as what we just discussed with the home. So I know I've said this a number of times, but these are the only HCPCS codes that require the price per unit. Okay, so this is what you would do on the care plan. You'll also need to do this on your service authorization. So your service authorization form obviously should match the approved care plan. And so what we have done is we have reformatted the service authorization form to hopefully reduce the amount of manual data entry that you're having to fill out. And so we've combined a lot of these elements that you're having to list before into a single selection. And then you're only going to have to manually enter some information for those HCPCS codes that we just reviewed. And I'll show you a picture of the service authorization form. identified some things that need to be corrected on it. So I'll resend that. And then I'd really appreciate it if you guys could take time just, filling it out, testing it to see if you like the layout, if the layout works for you, if the font works, because we really want this to be helpful and not more work. So the form itself looks the same. Where we've made changes is to that HCPCS section. So if you look where in this red box, this is a drop-down box. So you'll be able to select from the drop-down box the code, and it will already have the name, the frequency, and the cost, the allowable rate. So that's already entered for you. So really all you're going to have to do is enter the unit of service for that HCPCS code. You'll see that the next two columns for T2029, you'll have to list the frequency because that's variable given the nature of the code. And then as we just discussed, the price per unit. So if we look down below, we added T2029, special medical equipment supplies and supplements to the service authorization. You'll see that it just lists the code and the allowable service. So the case manager will need to enter the unit of service. So remember from our example, we had 2 units. You'll need to enter the frequency because that's variable. You're going to have to enter that. For nutritional shakes, it's daily. And then again, the price per unit is the cost per unit. So you'll need to enter that. So we're hopeful that by automating some of this, it will reduce what you have to fill out and also help ensure that the correct information is entered on the service authorization form. So with that, what other questions do we have? Let's see here.
Do you want me to read them off?
I have them, so I'll read them, but I don't know that I'll be able to answer all of them.
Okay.
But when there is a special circumstances or need for any of these services, I will send a detailed email explaining the justification. Once approved, comment about the approval. Is that process still okay? Yeah, I think that's fine. We appreciate as much detail as possible, whether you do that via email. I think sometimes if you know that that's a really unique circumstance, that's probably a better approach so we can talk through it before you enter it into the care plan, because we would hate to deny it if for whatever reason. But I also really want to highlight that putting those comments into, or the communication from the email that you've received from the New Choices Waiver team member into the comments is a really strong practice. That helps us as reviewers remember what we've discussed. So great approach to care plans.
And I guess I will add to that, Amelia, that in the instances when this has occurred, when you guys reach out to us in advance of submitting the care plan to get a prior approval, we always respond back, or try to respond back, and tell you to note that same justification in the comments section with the addition, previously I have communicated with Lainey and this has been approved. That's really helpful. We cannot move away from substituting the justification in the comments section with the justification via email, because our auditing process is done out of the care plan system. So please continue the excellent work you're doing, putting the justification in the comments section.
Lainey, I'm going to let you address these. The next two are similar, but essentially the question is, do we need to get the actual charge, the actual cost per unit from each provider, or can we just list the highest price? And I'm assuming, and then the subsequent question was for T2029. So I'm assuming this is to T2029. So we've listed that max allowable. So the question is, can we just enter the 1015 for wipes and the 285 for shakes, or do we need to get the actual cost from the DME provider?
The intention is for you guys to get the actual cost from the DME provider. When we were strategizing about how to operationalize this, the guidance that we got from leadership was that they did not want to have to create a separate MAR within T2029 for each DME item that could possibly be covered by New Choices waiver. That exists under the Medicaid state plan, but we did not want to do that for specialized medical because there is a lot of flexibility in that service description. And we would lose some of that if we had to create a rate sheet within that code. With that said, though, we wanted to provide case managers with a frame of reference so that you guys have an element of authority when communicating with the DME providers. So maybe somebody from the aging waiver side can chime in on how you guys establish the quote unquote budget or the rate amount, since aging waiver works a little bit differently where you guys assume responsibility of dollar amounts in your service authorizations. We stole this idea from aging waiver. So if anybody wants to chime in about how you manage this on the other side, feel free and just unmute and share your thoughts if you feel inclined. But our goal is for you guys to kind of help us and not let the range that we've set to just default to the max allowable, because there are providers who are charging less than this. So open to your feedback there.
So Lainey, on aging waiver, it runs similar to the way it's running right now on New Choices, where certain codes have a max budget, like the community code or the environmental adaptations code. But we are not at this point being asked to put the exact, have like a ceiling for like specialized medical equipment or anything like that on our care plans. Okay.
What is it that you do when you have specialized medical come up? What budget are you communicating, or is it just not communicated?
So, and other people like Tracy, feel free to chime in. So we have that operating authority on the local level.
Yeah.
Where we have the flexibility, as long as we stay within policy, we have the ability to do that. And then if it hits a certain threshold, then we escalate it to Tammy at the state.
We used to negotiate our own contracts for providers. And when we went to the PRISM system, that went away. Yeah. And so we actually don't put rates on service sauce anymore. We just put total number of units.
Per contract.
As per contract. And so some of that went away, but when we're buying and purchasing things and then billing on FTS sheets, say like for T2029, it'd be the exact amount of what we purchased. So if we bought a bed rail, it'd be for the exact amount of the bed rail. So we can't go over what we exactly paid.
Yeah. Okay. So I guess maybe you can help us here. We are open to feedback and adjusting this. We've got some time until April 1st to really fine tune this. This was our first stab at how we think this should occur. You know, you heard me earlier acknowledge that how we think things should occur is not always how it does occur in the field or the most practical. So in this scenario, our goals, April Fool's sounds like a joke. I didn't even think about that. You're right. Not a joke, sorry. So our goals with this are not to have all providers default to the range that we have set, you know, the $1 to $10.15 for wipes. I think that's what it is. We don't want to default. We don't want to be forced into creating an individual rate sheet within a rate sheet for T2029 for every possible item that specialized medical equipment will cover. And our third goal, and really what is prompting this, is to prevent waste, fraud, and abuse, which has been seen with this code specifically, with specialized medical equipment. So without any proper controls, there has been unreasonable billing by providers. And so this was something that the Office of Inspector General, we collaborated with them on to implement this practice because an issue was identified and we needed a strategy to fix it. So if there's something coming to mind on your end that you see a solution that we're not, please share your ideas for what you feel like you need from us in order to all, buy into this new process we're going to do. So on wipes, I can see that they only cost $1.96 at Walmart. Yes. That's true. So if you can imagine providers charging, double, triple, 10 times of the rate range we have set, that has occurred. And so we need a way to prevent that. My concern would be providers will always want the highest allowable. They may get the wipes at 5, but want the highest possible of 10, 15. Yep. That's true. And I don't know if this is the point where we're at, where we just have to accept that wipes and Ensure shakes are the only two that have a default of 10, 15 for everything. If that's what this is coming down to, and all providers, you guys feel strongly that all providers are just going to default to that, then I think we will need to re-examine that rate, because there were many providers who were charging less than that. So we will need to kind of shift the average, or at least have that discussion higher up on the chain within Medicaid, so that what occurs does not throw expenditures too far away from historical trends. Any other concerns that you see with this process as we've outlined it? Tracy, I see your question about chore services. You currently get bids on chore services?
So an aging waiver, we pay per bid. And so we get like a bid on our chore services, and that's the rate we'd put in. And so I just was thinking that in typing.
Yeah, it is okay there on chore services if you default to the max allowable rate of $477. I understand that depending on the nature of what chore services is being used for, it may be appropriate to get bids. So we've had instances where disaster cleanup is needed and bids were obtained, and then units kind of manipulated to cover the cost. And in that sense, in that case, that is appropriate. Also, which is why we're moving towards an episodic rate. And we will explain all of that when it happens. So Tracy, I appreciate that what you're saying where you get bids, because sometimes it is appropriate for chore services for episodic jobs like disaster cleanup. But if it's for an ongoing hoarding situation, you are fine to just note $4.77 per unit.
So Lainey, there's a few other questions. I know we're at time, but if people can hang out, I think we can get through these pretty quickly. I'll just address 2 real quick, and then I'll let you address the other ones, Lainey. So the question about the new service authorization form, will it cover all HCPCS to include All of them, yes. So you won't need two forms. I think that was the concern. So when you look at that form that we sent out, you'll see that in that first column where it said HCPCS service authorization, there's a lengthy drop-down menu where you can select the HCPCS code. So this would be the service authorization that you would use for all those codes. And again, go ahead and play around with it. And if you think the functionality isn't working or have questions or concerns, let me know. The other question is, where did we get the average cost for the wipes and shakes? That was from, Lainey mentioned working with OIG. They had a list of what DME providers had billed Medicaid for those services. I believe there were 12 or 13 providers. So we had their cost per item, and we just took the average of those costs. So that was their actual cost that they were billing Medicaid. This does go in effect April 1st. Lainey, this is an operational question. Do we need to update every existing provider authorization form, or just use this new form and process for new clients and annual updates or changes starting April 1st?
That's a good question.
Yeah, I don't think we had thought through that one. So that was a really good question.
I appreciate this question. Don't judge us for not having the answers figured out. This is why we're asking you, because you guys have some great questions. We have a team member on our team who is our voice for these type of questions. So we appreciate it when we get these types. So I think it would be a lot easier to adopt this process to just start with new changes and care plans that are being submitted. So when we kind of flip the switch and make those fields required, as of April 1st, they will be required for any new change that is made. And any new care plan is submitted. So that will be a graduated approach, and I think that is probably more feasible for everybody. So I'm okay with that. There won't be a need for a massive rework cycle for all participants' care plans within your agency.
Great. And then the other comments are just kind of about how aging handles the process. So Lainey, I think we can talk through that. It sounds like the CMAs are allowed to purchase the wipes and shakes directly. So they purchase them at Costco and Walmart, and they don't use a DME provider. So the question's about whether or not that would be possible for New Choices waiver.
Yep, that's always been an option. It's one that we recognized was kind of an outcome of FTS. So if that's something that the client wants, they prefer for you guys to purchase those items, say, off of Amazon, and then you submit the FTS request form rather than going through a DME company and the DME company billing Medicaid, and you want to prepay that, that is allowable as well. You just can't bill Medicaid directly in normal times. During Appendix K, you can, because that allowance is in place. But I understand that front loading that much money may not be feasible for everybody. And so, there's a balance there.
So a follow-up question to that, Lainey, if we are allowing that, can CMAs bill the time for shopping to purchase those supplies?
Let me get back to you on that question. I think that's a good question. We'll make a note of that and follow up.
Yeah. Okay, I think that's, okay, good clarification that aging waiver does not allow time for shopping, so that's helpful.
Thank you.
So I will, just to conclude this discussion piece here around the price per unit, I will send out the guidance again, maybe add some clarification based on what we just discussed, specifically about how this should be applied moving forward as of April 1st. And then I will also send out the revised service authorization form, and I'll send that out to the supervisors.
Great. Thanks so much, Amelia. Thanks for staying a little bit over time, everybody. We really appreciate this forum. I don't know how you feel, but I'm really liking it. So we might do it more often. So stay tuned, and we welcome any feedback you have about how this went or what you'd like to see happen as far as frequency in the future. I already see one person say we need to do this more often. I kind of agree. Maybe next time we'll have a cameras on requirement so we can see everybody's faces, because that's the part I miss about in-person trainings. So anyway, I hope you guys have a great rest of your day. Thanks for joining us, and thanks for all you do. We appreciate all the work you've done over the last year specifically. So have a great day.
Thank you.
Thanks. Bye, Shauna.